Hello there, this is Dr. Mintz. This is a patient who presented with left inguinal pain and fever. I'll give you a chance to look over the case in its entirety. An obvious abnormality there in the left inguinal region. But before we go to that, we'd like to make sure we look at all of the anatomic structures. And my list of structures, the way I go through it, is liver, spleen, and pancreas, gallbladder, adrenal glands, and kidneys, and abdominal aorta. So first we look through the liver, the spleen, and pancreas appear normal, no pancreatic abnormalities. The pancreatic tail always points to the splenic hilum, and this seems to be an exception to that case, but actually the pancreatic tail turns upward and sure enough goes right exactly to the splenic hilum. The adrenal glands, here's the left adrenal, here's the right adrenal, they both look normal. The kidneys and gallbladder appear normal. A tiny little defect in the upper pole of the right kidney is noted that looks like it's fat containing. It could be a very small angiomyolipoma or perhaps a small cortical defect, and that we're actually seeing some of the perinephric fat in that small defect, but in any case it's not significant. Abdominal aorta appears normal in caliber. Gallbladder appears mildly prominent, but it doesn't measure 10 centimeters, so this may be a reflection of the fact that the patient may not be eating much, and when we eat, the gallbladder contracts, particularly when there is fatty materials in the food that we're eating. So it may be that this patient is because they're sick, they are just not eating, and the gallbladder therefore is not contracting. Okay, now we go down to the finding. Here we have something herniating through the left inguinal canal into the left hemiscrotum. It looks like bowel. The bowel has edematous wall. There's stranding around it. So this is very suspicious for a hernia where there is vascular compromise and resultant bowel ischemia and associated inflammatory changes related to this bowel ischemia. So this is a life-threatening situation. This will need to be operated on urgently. We need to tell the surgeon where to look, and it's not enough to just say that it's in the left hemiscrotum. We have to say what part of bowel is involved. So if we look here, we see, well, this looks like left colon, and left colon courses down like this, and here's rectum. So this is sigmoid colon going backwards here, sigmoid colon, and so this is proximal sigmoid colon, and the sigmoid colon doesn't appear to be involved. And initially that's what I would think. If there were colon in the left inguinal canal, the most likely candidate for producing that would be the sigmoid colon. But in fact, if we look closely here and we follow these two segments, again, we're in the inguinal canal here, inguinal hernia, we have these two segments here. Follow those, see where they go. We follow those up superiorly, and one is just proximal to the splenic flexure, and the other is in the mid-transverse colon. So this is actually mid to distal transverse colon, which has hung down very low down into the inguinal canal and herniated into the inguinal canal and into the left hemiscrotum. So what we have here then is transverse colon, a segment of which has herniated inferiorly. It's draped downward and herniated into the inguinal canal on the left and into the left hemiscrotum, producing vascular compromise to the involved segment of transverse colon and as a result we have a surgical emergency here.